Thank you all for joining today, and thank you for our partner in today's Lunch and Learn, UPMC. Today we're talking with cardiologist Dr. Elizabeth Piccione. She's the interim president of UPM Jameson and UPMC Horizon. Dr. Piccione has over 17 years of experience in inpatient and outpatient setting as a non-invasive cardiologist and helped to develop the Women's Heart Program at McGee Women's Hospital. So today Dr. Piccione is going to talk to us about heart disease risk factors in women and what we can do to minimize risk. Thank you for joining us today, Dr. Piccione.
Thank you. Thank you very much for having me. So this is truly a, no pun intended, a topic that's very near and dear to my heart. And we're going to talk about some risk factors that are unique to women and things that a lot of times women don't even realize contribute to their overall cardiovascular health. So thank you for having me. And I have some slides we'll talk through, and then any questions or concerns or any issues anyone has, I'm welcome to field any questions in the chat or after the slides are done. And Donna is going to do my slides for me because I'm technically challenged. So, so very good. So next slide. So I just want to talk about, if you asked women what they thought their #1 health risk is, women tend to quote breast cancer or cancer in general as their leading cause of death or severe illness. And in actuality, cardiovascular disease by far is the leading cause of death amongst women. And if you see the red line, just looking at how the red line's above the blue line, so in reality, the risk of dying, more women actually die of heart disease than men. And I think this is shocking because if you ask men what they were most afraid of and they thought their biggest risk was, they would identify correctly heart disease. Women do not, but we are much more likely to die from cardiovascular disease than anything else. All cancers combined together don't come close to the risk of cardiovascular disease in women. Next slide. So some of the things I just want to talk about is identifying non-traditional risk factors in women. And we want to talk about different etiologies of chest pain. Not all chest pain is caused by blockage in a major vessel, and a lot of times goes under or undiagnosed. We want to talk about barriers that contribute to the disparity in our cardiovascular care. Now, when we use the word ischemic heart disease, that means heart disease that's caused by blockage. So if we think of the heart as a house, it has pipes, and those pipes are the arteries that supply blood to the heart. And when there's blockage, which is a very common type of heart disease in women and men, that's caused by blockage, we use the word ischemic. So really this is talking about what are risk factors for women to have disease of their pipes. Next slide. So you have a lot of traditional risk factors. You can go ahead. There is cholesterol. That's the cholesterol that comes to the top of your blood. Blood pressure, hypertension, extremely common in women. We're not just all nervous and anxious. We actually have a high incidence of true high blood pressure. Sugar and diabetes. 90% of all diabetics will suffer from some type of cardiovascular disease. Smoking. And the bad effects from smoking cigarettes seem to affect women more than men. So that's also an issue that really is important for anyone, but especially for females. And abdominal weight gain, as we get older and sometimes less active, we tend to notice that we accumulate weight in our abdomen, in our belly area. That can be a precursor to diabetes and increases our risk for heart disease. And also sedentary lifestyle, not exercising, sitting down, not being regularly active. And genetics. And if you are a female who has a primary relative, that means your mother or your sister, mother, father, brother or sister that has heart disease, that's a primary relative. And if you have a woman who's a primary relative who's under the age of 65 when they're diagnosed, you have a genetic predisposition for cardiovascular disease. Doesn't mean you'll get it, but it means we have to keep you on a little bit of a shorter leash. And next slide. So if you look on the left, those are the traditional risk factors that a lot of people are aware of: diabetes, smoking, obesity, inactivity, high cholesterol. But I want you to draw your attention to the right side of the screen. There are significant risks that are female-centric that a lot of women aren't aware of. And one includes preterm delivery, high blood pressure when you're pregnant, gestational diabetes. So the top three are all things that happen to females when they're pregnant. So as I'll show you in the upcoming slides, when people are pregnant, it's a stress test for the heart. You need a lot of extra heart activity in order to have a regular healthy pregnancy. And because women tend to have their children in their early 20s and usually before the age of 40, a lot of times they are not aware that issues that arise during pregnancy make them a significant increased risk of heart disease in the future. Also, autoimmune diseases. The most common being lupus, rheumatoid arthritis. These are much more common in women because we have stronger immune systems, but these increase the risk for cardiovascular disease. Breast cancer treatment, both chemotherapy and radiation, especially to the left side of the chest, which is over the heart. Unfortunately, we have way too many women with breast cancer, and their treatment does increase their risk of heart disease later on. And one of the things I think that people find interesting is depression. And as we go through this talk, I will remind you that your head is attached to your body because one cannot run without the other. We cannot separate our brain function from how the rest of our body functions. And when people suffer from major depressive disorder or even seasonal depression, any type of increase in depressive symptoms can increase their risk of heart disease. And we'll talk a little bit about why that is coming up here. Next slide. So as I said, pregnancy is a stress test, and this is why it's a stress test. Next slide. So again, the important thing about this slide is the blue line is the amount of blood that's going to come out of your heart, and it goes way up during pregnancy, way up. Your blood pressure will stay the same because your arteries actually enlarge, but your cardiac output, the amount of blood coming out of your heart, has to go up in this huge amount to support not only your cardiac health, but also the health of the growing baby. And as you go through pregnancy, it sustains all the way through pregnancy. So it's basically a stress test for your heart. And those are normal changes that occur with pregnancy. Next slide. So when people have preterm delivery, which is defined as delivering less than 34 weeks, go ahead and hit the button. Those people have 1.5 times higher risk of coronary disease in the future. They have 1.8 times the risk. So if a normal person's risk is 1, if you had preterm delivery, you have 1.8 times the risk of dying from a cardiovascular reason. Next bullet. Preeclampsia, which is high blood pressure when you're pregnant. Also, a lot of swelling can occur with preeclampsia. It's commonly associated with high blood pressure, but it has other symptoms that go along with it. So what are the risk factors? If you're over 40, Black race, if you've had preeclampsia or gestational hypertension, so you've had previous complicated pregnancies, if you have high blood pressure and get pregnant, people who are obese, have high cholesterol, diabetes, and then get pregnant, or people who have kidney disease are at increased risk for preeclampsia. And we probably all know somebody who was like, oh, they get very swollen at the end of pregnancy and their blood pressure. A lot of times they have to take blood pressure medication. Next slide. So again, just to point out, if you look at the far right, if you have preeclampsia when you are pregnant, your chances of having high blood pressure down the road, this doesn't mean in the 1 year or even 5 years from the time you're pregnant, but we're talking about over your lifetimes, you are 3.7 times more likely. Having blockage heart disease, 2 times more likely. Having a stroke, 1.8 times more likely, and having a blood clot, really close to 1.8. So these things matter. Our health and these are really important things for women to realize, that when they have had issues and complications associated with pregnancy, that they need to be followed closer throughout their life because it's a significant increase in risk. Next slide. So, and again, looking what happens when people have high blood pressure when they're pregnant, or if they have severe preeclampsia, and they tend to develop high blood pressure. So it's not that the pregnancy caused the high blood pressure, it's that they had a tendency and it accelerated the diagnosis. Next slide. So, again, if you have, when we look at relative risk, so one being normal, any of those risk factors increase your risk of subsequent heart disease almost 2 times. Next slide. So I also want to look at autoimmune diseases, and that's IHD would be ischemic heart disease, but autoimmune diseases, just for some background, are much more common in females. We tend to live longer than our male counterparts because we have more active immune systems, but we have a higher incidence of diseases where our body attacks itself. Again, the most common being rheumatoid arthritis, that's pictured there. Next bullet. This is the rashes associated with lupus. So probably those are the 2 most common, but again, there's other autoimmune diseases that occur, especially Sjogren's syndrome. There's a plethora of different things where our immune system goes a little haywire. Next slide. So this was just a study looking at another risk factor that I think we don't realize is that for radiation therapy. Fortunately, we're diagnosing people earlier with breast cancer, but again, we're diagnosing a lot of people. And when you look at those people, really what this is showing is, go ahead to the next slide, significant increase that doesn't start to show up until about 10 years after the time of radiation therapy. But if you have left-sided chest radiation, there are much higher rates of events, and it increases 7.4% for exponentially every time you have more radiation dose in and around the heart. Next slide. And then I want to talk about depression. This was interesting. When they started to look at depression in women who were hospitalized with heart disease, it was alarming. There was a huge incidence of people diagnosed with depression secondary to already have been diagnosed with a heart attack. And for a lot of people, especially females, depression is part of the picture. And again, I want to emphasize, especially since everybody's gone through a lot over the last 2 years, you cannot separate your brain from the function of the rest of your body. And when people are feeling depressed, or to be honest, overly anxious, whenever people suffer from mood disorders, it gives your body a sense that it's under attack, and your body produces more fight or flight chemicals. So your adrenaline levels are much higher. Your levels of certain chemicals in the body that can cause high blood pressure and swelling tend to go up. And so what occurs is your body, you can have an increase in inflammation, an increase in heart attacks, because your body feels that it's under stress and it responds in a maladaptive way. Next slide. So what I always tell when women say to me, what can I do? Because on the slides that I showed you, some of those unique risk factors, in addition to the traditional risk factors for females, those don't doom you. In fact, if people have a strong family history of coronary disease, and we try to control for the things that we know help, smoking and high blood pressure and inactivity. If we know that somebody's had radiation therapy, we tend to watch their cholesterol a little bit closer. We want to make sure people don't become diabetic or try to manage their diabetes aggressively. So everybody's homework is to know your numbers. You want to know what's your blood pressure, what is your cholesterol, and you want to know what your risk factors are so that you can always address those. And I really encourage everybody to be very proactive. So many women go to the doctors and they take their blood pressure and it's high, and they say, oh, you're just nervous. Maybe. None of us particularly like going to the doctor, myself included, but we also might have high blood pressure. Our arteries are smaller. And it's very easy for women to develop high blood pressure because as we age, our smaller arteries get stiffer and your heart has to work harder to pump blood through those stiffer pipes. So it's very easy for women to become hypertensive. Next slide. So when we look at what does it feel like, what do people feel like when they have a heart attack? Well, only people who have heart attack know what it's going to feel like for them. And for most people, women and men, our traditional risk factors of chest pain, discomfort, a tightness over their chest, nausea, lightheaded, and pain, discomfort that goes to the jaw, or radiates to the back or down your left arm are still the most common. Shortness of breath when they do things. Next bullet. But for a woman, we have a much higher incidence of atypical symptoms. So you might have upper body pain. You can have back pain. I've had people tell me they have a band around the back of their chest. You actually can have stomach issues that are new. So the symptoms can be very atypical. Next slide. And so you really want to make sure women tend to have much more indigestion. And also the number 2 symptoms of heart disease in women, the second most common after chest pain is fatigue, feeling tired. I don't know about you guys, but I feel tired a lot. So it's very hard to know, the symptoms can be extremely subtle. So it's very important that we all pay attention to changes. Nobody should start getting indigestion when you carry your groceries up the steps. Indigestion should occur after you eat Mexican food and lay down. So you always want to be aware, not of what the symptom is, but when did you notice it? What is the pattern? Is something that you're doing change? Is it harder for you to do something? Or are you noticing that your jaw hurts when you're cleaning your house and when you stop, it goes away? So you want to pay attention. It can really, heart disease can stalk you in private and you don't realize it's going on. It's not always obvious. So women, again, unexplained fatigue, palpitations, fainting and dizziness, those are really common and again, atypical symptoms. And again, people do tend to have the arm, back, shoulder, and neck pain, but these other symptoms are very common as well. Next slide. So what happens to us? What happens to women when they have a heart attack? And this is what's disturbing. And one of the reasons I always like to reach people with these talks is that women are more likely to die. So in the first year after a heart attack, 44% of women versus only 27% of men at 1 year. And this was, in a study looking at comparable rates of women and men. And when you look at sudden death, so people who unfortunately have an electrical abnormality that causes people to die suddenly, 64% of women as compared to 50% of men who were reported to have no previous symptoms, but we'll talk about that. Women develop more chest pain, more heart failure, and more electrical problems after they have heart attacks. And why does this happen? One of the biggest reasons this happened is women are underdiagnosed. Because the symptoms of heart disease tend to present as when I'm doing something, they occur, and when I stop, they go away. Women are much more likely to ignore the symptoms. They tend to be caretakers. They're busy. They are responsible for other people. And so women tend to ignore their symptoms. So we don't die because we get worse disease. We die because we are neglecting ourselves and are not actually thinking that this is something that's dangerous. Next slide. And again, this is just looking at that women that are young have actually the worst outcomes. And again, almost all of this is related to when they present and how aggressively they're treated. Next slide. So 5 years after somebody has a heart attack, if you're less than 45 years old, 47% of those women, those women will die. I mean, that's terrible. I mean, that's actually And this is, this is improving year after year as women do become aware and know that this is something that's an issue, but it commonly is underdiagnosed. And women also tend to receive less intervention. So heart catheterizations, which are fancy x-rays that we look at, when you look at even knowing what your cholesterol is and should your cholesterol be treated, women are less aggressively managed. Heparin and beta blockers, these are medicines that you use when someone's having a heart attack. Women are less likely to get them. Antiplatelet therapy, these are blood thinners for women after they've had heart attacks, kind of like super aspirin, and they are prescribed less for women than men. There's also less referrals to cardiac rehab, which helps people build up their strength after a heart attack. And ICDs are devices, they're electrical devices that can prevent sudden cardiac death. And so if you have equally recognized indication in your woman or man, the man is much more likely to get referred to have this device than the females. Next slide. And when we look at heart catheterizations and bypass surgery, many more men are referred for more aggressive therapies than women. Next slide. So one of the things I want to say before I talk about this slide, it does not mean that we are doomed. What it means is that we need to always be aware and educate ourselves. We need to take our symptoms seriously. And we also need to advocate for other women that we know and love so that they know what their risk factors are. They know to seek medical intervention. A lot of this is just related to the fact that there's less intervention when women and men have the same disease process. So I also want to talk about other types. When we were talking about ischemic disease, so that would be a plumbing problem in a big artery. Some of you may know people who had chest pain, exertional chest pain. They're walking up the steps, they get chest pain and shortness of breath. When they stop, it goes away. And they have a heart catheter worked up, they have a test, they have check or cash. They have different things done.
Okay, do you know what you need? Or is that what you just need?
Have any significant block?
Yeah, it's for 12 of them. It'll be
and a lot of those women will say,
okay,
what's wrong with me? I had a heart catheterization.
All right, thank you. I will try to get that.
So 50% of women
okay,
who have
alrighty, thanks, bye.
and have a stress test, have a heart catheterization, have all of this workup, they think their tests are normal. Our tests are normal. It's not me. It must be in my head and I must be crazy because men are sick and women are crazy. So 50% of women have no chest pain when they have no significant big blockages when they've had a heart catheterization. Next slide. However, what we again fail to realize is that not all people who have normal heart catheterizations have normal arteries. Next bullet. So there's a lot of things that can cause chest pain, and there some of those are listed there. Blood clots in the lung, esophageal spasm, acid reflux disease, hernia, pleurisy, pneumonia. And how do we know the difference? It's really important that we pay attention again to the pattern. What do we feel with our symptoms and what are we noticing in and around the time? And so sometimes the chest pain is caused by these things when our arteries are normal. Next slide. But sometimes it's not. Next slide. So if you look at this picture, I want to talk about something called microvascular dysfunction. And in English, that means the smaller arteries. So the big arteries will break down into smaller arteries. And you can have, when you have a heart catheterization, you're looking at big arteries. The small arteries are lined with like an elastic muscle tissue, and that can spasm down. And women have a higher incidence of what we call microvascular dysfunction. The little arteries are irritable, either because they have some blockage in them, because we have high blood pressure, because we tend to have our bodies respond by clamping down those arteries much more so than men. And microvascular dysfunction, the symptoms will mimic large blockage. And so your heart catheterization will look normal, but yet we know that people have microvascular disease. And there are some sophisticated tests that help to diagnose this, but honestly, clinically, it's fairly typical. You have symptoms that really are consistent with exertional, when I do something, chest pain or shortness of breath. You're not crazy. This may be what you're suffering from. It's very common in people with high blood pressure and diabetes and people who smoke. Next slide. So some of those cardiac MRIs and not all cardiac MRIs, so there's a more sophisticated cardiac MRI that can diagnose this. There's a PET scan, different contrast, but honestly, again, it's really something that you want someone who's going to listen to your symptoms and take you seriously. It can be diagnosed clinically. Next slide. It also can be treated. And we treat it with medications that help these arteries not to clamp down, that help them to relax. And a lot of times these medications, will treat people with them to see if they improve. And that helps us to make the diagnosis. Lifestyle modification like exercise, certainly stopping smoking, cholesterol medications, and then the top two, beta blockers and calcium channel blockers, can decrease heart rate and can also help to make vessels open up a little bit. Next slide. So again, vasospastic disease. What is this? This is not blockage disease. Vasospastic disease is almost entirely a disease of females, and especially, unfortunately, females who smoked. This is also seen in younger women. And this truly is the artery getting very irritable, and it can clamp down. And this tends to occur in people when they're asleep and they wake up with chest pain. It comes out of the blue. This is not the type of symptom that occurs with exertion. Something triggers the artery and it clamps down, and people get sudden heart attack-like symptoms, but there's no blockage when we go looking for it. And the reason there's no blockage is because it actually is not a plumbing problem. It's a problem with the wall of the vessel being too reactive. Next slide. So this is what a normal artery looks like. It has some layers to it. Next slide. But one of the things that this is, again, something that's more common in women, is if you took 3 pieces of saran wrap and put them together, that's kind of the wall of an artery. Well, on that slide, women can get a tear in one of the saran wrap layers, and blood can actually come behind that, and it can make the layers start to separate. And that's referred to like as a hematoma or an intimal rupture. It's spontaneous. It just happens, and happens much more common in females. And actually, this is dangerous because this tends to occur in women not uncommonly after they're recovering from pregnancy. It's thankfully on the rarer side, but we definitely see it. Next slide. So we refer to it as spontaneous coronary artery dissection, and dissection means that the artery tears. And you'll hear this talked about as SCAD. Again, being a condition that is almost exclusively found in females. This tends to occur in women when after they've been pregnant and close to the time that they've delivered. Next slide. So why do women get this? It has to be related to something that's connected with pregnancy and post-pregnancy. And so we think that there's many contributors: estrogen, testosterone levels, maybe that there was some other disorder that affected the inflammation in the body that is getting triggered after pregnancy. Next slide. This also tends, again, extreme stress, recreational drugs, and again, the peripartum state. Next slide. So how does this present? Because again, unfortunately, this is something that can be missed. But when an artery tears like this, it causes severe chest pain because you're not slowly building up blockage that your body might get used to. All of a sudden an artery closes and they tend to have severe chest pain. Next bullet. Arm pain radiates down the left arm, and nausea, sweating. The symptoms can tend to be very quick in onset and fairly severe. Next slide. So is this related to estrogen? What does estrogen have to do with our cardiac health? And this is a question we're still trying to answer. Many years ago, some of you might remember, people were actually prescribed estrogen if they had a heart attack. Women were just prescribed estrogen. Then we found that actually that was not helping, and in a lot of cases that actually caused issues in people who were more likely to develop blood clots. However, we know that there's some positives of estrogen, because women tend to develop heart disease about 10 years later than men. But once we're postmenopausal, we catch up very quickly. So there's some protection to women when they're before menopause. So we are actively looking at this because there is some protection. And we know that when people have estrogen deficiency, when they're postmenopausal, there's an increase in the bad cholesterol, there's a decrease in the good cholesterol. And when I say that enhanced endothelial function, that's the muscle that makes the artery open and close. So arteries tend to be more relaxed and relax easier prior to us going through menopause. Next slide. Next slide. So again, why is this worse in women? So we don't even realize it's a problem, and that's part of the problem. And there's also a lot of risk factors, a lot of high blood pressure, diabetes, and also, again, pregnancy increases our risk, especially it can put a stress on your body. Lack of awareness of symptoms, delay in presentation and diagnosis. And men do have an increased risk on presentation is part of this that more men suffer from electrical issues. This is probably less likely as much as the ones above it. Next slide. There's differences in women and men. So our arteries are already starting off smaller. Our hearts are smaller. Our hearts tend to get a little bit stiffer. So there's just chemical differences to the way females and males' bodies are made up and the way that they respond to stress. And again, if you look at these, the biggest issues here are differences in treatment. Women aren't as aggressively treated and they present late. Those two things are probably the biggest driving factors behind why we see women die more of heart disease than actually their male counterparts with the same disease. Next slide. So blood pressure, treating with cholesterol. Now, not everybody needs to be on cholesterol medicine. If you're a healthy 30-year-old, you don't need to be on cholesterol medication. But people who are diabetic, all diabetic patients should be on cholesterol medication. And when we looked at female diabetics, there are way less that are treated. And also cardiac rehab. After somebody has had an event, it's really important that they get up and get going and moving, and we have less incidence of being referred for cardiac rehab. Next slide. So if you look at these, there's a lot of reasons why women tend to have disparities in their heart care. There's, access issues, health literacy, we're just not aware, the education, the cultural beliefs that this just isn't an issue. Also, on the physician side, on the provider side, we need to continually, and we're always trying to educate our providers that this is a problem in women and we need to take it very seriously. And then institutional barriers. It's hard. There's not hospitals everywhere on every single corner. It's not easy for people to get cardiovascular care, to have access to it. Next slide. So we really want to look at patient education. I think that knowledge truly in this case is power. Next slide. So there's a lot of national initiatives. The Go Red for Women campaign is, you may have recently been exposed to in February by the American College of Cardiology. The Know Your Numbers campaign, which is basically know what your blood pressure is, know what your cholesterol is. We also need to self-monitor. We really need to know, you may ask your friend, did you have your mammogram? How many of you like ask your friend, like, what's your cholesterol? It's just not something that we tend to talk about as much. So we're looking at different things, electronic communications, and different videos like this, handouts, reference materials to try to get the message out. Next slide. So in conclusion, traditional risk factors. So if you are diabetic, have high blood pressure, previous smoking, hopefully not currently smoking, and have high cholesterol, they actually affect women even more than they affect men. So traditional risk factors can portend a higher risk on females. Next bullet. However, it's really important to know what your non-traditional risk factors are. You want to make sure that you're aware, did I have problems with my pregnancy? Do I have a autoimmune disease? Things that really significantly increase our risk and are much more frequent in female population. Next slide. Also, we may present with atypical symptoms. It is not obvious. I have had many times throughout my career, people tell me, it is my gallbladder, I'm having a gallbladder attack. It may feel like a gallbladder attack. The way the inside of your body is wired, I could touch your liver and you'll feel it in your chest, and I could touch your heart and you're going to feel it in your belly. But when symptoms are new, when GI symptoms, so anything in the stomach and related to eating, are not actually related to eating, but are just occurring, and especially with exertion, please take those seriously. Next slide. And also, anybody who has chest pain, we always want to have a reason. There's a lot of people walking around who have, well, you had a stress test, it was normal. You had a heart cath, it was normal. Therefore, your chest pain is not cardiac. If you have chest discomfort and shortness of breath when you do something and it goes away when you stop, there is likely something that we can do to help with that. When disease is from small vessel, thank goodness it's less dangerous. It's less likely to lead to very bad things like heart attack and death, but it can cause significant decrease in quality of life. And what we know is that people, if they have discomfort when they do something, over years, they tend to do less and less and less. And so this can significantly affect the quality of life. And also, women who actually progress to an acute MI, so acute heart attack, have worse outcomes. So, we always tell everybody, we want to, and I tell all my providers, check your bias at the door. Like, we have to treat all patients the same, regardless of whether they're female or male. And currently there is more research going on. A lot of our studies were based on men, and now they're currently doing much more female focused research. There's a lot more women involved in this field. And so I think there's very good things and good information that will come out. Next slide. And I always say, tell everybody heart disease is a leading cause of death in women. 1 out of 3 women are actually going to die from a cardiovascular reason, a heart attack or stroke. Men are different. Women are not going to present the way it does in the movies with like, oh, I have an elephant sitting on my chest. And always take persistent chest pain seriously. Don't be afraid to come to your doctor. If people come and they see me and I can tell them that it's non-dangerous chest pain, I'm very happy that they came to check it out. Don't think that you will have to know ahead of time that you have something wrong with your heart before you seek a diagnosis or treatment. Don't ignore your symptoms. I cannot tell you how many times I've noticed that symptoms actually, the only time people realize how bad their symptoms were is when we fix something. And then they're like, I can't even believe how tired I was and how much discomfort I was actually having. Next slide. So I am blessed to be part of a group of cardiologists, both locally and at McGee Women's Heart Center, that are dedicated to treating. I treat all patients, but there is a emphasis on treating females. There is a group, and the main group of we have one of the largest women's cardiology programs, and it's centered at McGee Women's, and they really do a lot for focusing on issues that are unique to women. So please don't ever be, not that you have to drive there, you can go to your regular primary care doctor or see anybody, but please make sure that you check your numbers and know what your personal risk is. So I'm happy to answer any questions. I hope that was good information for you all.
Thank you so much. That was great information. Jess, you can go